Better. Go ahead.
Okay, sir. Uh, Epidemiology may the multiple gestation may be monozygotic or dizygotic. Monozygotic, which occurs when a single fertilized ovum divides into two distinct individuals after a variable number of divisions. Dizygotic, which occurs when two separate ova are fertilized. And presentation may be a monochorionic, sir, monochorionic, monoamniotic, and are monochorionic diamniotic or dichorionic diamniotic, sir. In all monozygotic twins, monochorionic, monoamniotic, and monochorionic diamniotic and dichorionic diamniotic will be possible. In only dizygotic twins, only dichorionic diamniotic presentation is possible, sir. In monozygotic twins, if twinning occurs first 2 to 3 days after fertilization, results in dichorionic diamniotic. If twinning occurs 3 to 8 days after fertilization, results in monochorionic diamniotic placenta. If twinning occurs at the 8 to 13 days after fertilization, results in monochorionic monoamniotic placenta. If twinning occurs at 13 to 15 days after fertilization, results in conjoined twins with monochorionic and monoamniotic placentation. Chorionicity is best determined by ultrasound in the first or early second trimester. It is important to know chorionicity because it determines the likelihood of vascular communications which occurs in all monochorionic monoamniotic placenta, which leads to twin-to-twin transfusion syndrome and it results in intrauterine fetal death, sir. What are the physiological changes in multiple gestation? Of interest to anesthesia provided due to multiple gestation, anatomical and physiological changes uh, accelerates and exaggerates, which intensifies cardiovascular system and pulmonary changes of pregnancy. In contrast to singleton fetus, renal, hepatic, and CNS changes resemble same due to increase in uterine size, which leads to decrease total lung capacity and decrease functional residual capacity, which leads to development of hypoxia rapidly during the period of hypoventilation or apnea. Uh, Due to increase in uterine size leads to displaced stomach cephalon, leads to decreased lower esophageal sphincter tone, which leads to increased risk of passive regurgitation and potential pulmonary aspiration of gastric contents, sir. Of all these above factors, which leads with increased breast size, leads to increased risk for difficult intubation and ventilation, sir. Other changes in multiple gestation is increased plasma volume, increased cardiac output. There will be increase in stroke volume around 15%, increase in heart rate around 3.5%, decrease in total vascular resistance, sir. Large fetal weight plus large amniotic fluid volume leads to aortocaval compression and which leads to supine hypotension syndrome, sir. Uh, there are a few complications associated with multiple gestation, sir. Fetal complications and the maternal complications. Fetal complications associated with multiple gestations are preterm delivery, congenital anomalies, polyhydramnios, cord enlargement, and umbilical cord prolapse, fetal growth retardation, twin-to-twin transfusion syndrome, and malpresentation, sir. There are few maternal complications associated with multiple gestation are uh, preterm labor, prolonged labor, uh, preterm premature rupture of membrane, preeclampsia or eclampsia, placental abruption, DAC, disseminated intravascular coagulation, uterine atony, and antepartum hemorrhage or postpartum hemorrhage, sir. For twin-to-twin transfusion syndrome, uh, deep arteriovenous anastomosis leads to twin-to-twin transfusion syndrome, sir, which occurs where one twin is recipient, other twin is donor. That recipient twin is like plethoric, having a risk of volume overload and cardiac failure, where other twin, which is donor, which, converted to fetal growth retardation and intrauterine death, and having anemia, sir. Therapies for this twin-to-twin transfusion syndrome are decompression of amniocentesis and amniotic septostomy, interruption of placental vessel communications, and selective feticide, sir. The main anesthetic management during this uh, therapy mainly focus on uteroplacental circulation, achieving profound uterine relaxation, optimizing surgical conditions, monitoring fetal hemodynamics, and maintaining maternal and fetal risk, sir. Order of delivery compared to first one, twins second one having a higher incidence of adverse outcomes due to low birth weight, malpresentation, umbilical cord prolapse, placental abruptions. Occurs due to rapid decompression of uterus and delivery of the first twin due to shear force through the basal part of the placenta, sir. And why this delivery of second one may requires sorry, sir. Delivery of second one may requires internal podalic version. According to studies, administration of epidural neuraxial anesthesia may provide outcomes compared to, improve outcome compared to general anesthesia, sir. Our anesthesia management mostly very depends upon the method of delivery. When it is labor and maybe the method of delivery may be labor and vaginal delivery. And second option is when vaginal delivery of the twin A and operative delivery of the twin B. Or third option may be cesarean delivery, sir. If method of delivery is labor and vaginal delivery, should aim for epidural analgesia, which provides optimal analgesia and flexibility for subsequent needs. Anesthesia provider should be vigilant because of due to obstetric conditions. The anesthetic requirement may change rapidly due to high risk of cesarean section in multiple gestation. If there is any question regarding the localization or efficacy of the block, the catheter should be removed and replaced. Due to high risk of aortovenal compression and hypotension, use of full left or right position after epidural analgesia to reduce the risk of aortovenal compression. Aortovenal compression. Secure large bore IV cannula in view of high rate of uterine atony and leads to PPH. Should deliver in a room where an emergency abdominal delivery can be performed immediately. As the time for the delivery of the twin A nears, the epidural analgesia is evaluated once more and augmented if necessary. Avoid motor block so as to put patient push effectively. Anesthesia should be effective so that should facilitate internal podalic version and total breech extraction of twin B if necessary, and also extension of anesthesia for the cesarean delivery if necessary. At least one member of anesthesia team should stay with the patient until twin A is delivered and twin B is either delivered or vertex is well applied in the pelvis. Sometimes we prefer continuous combined spinal epidural anesthesia for vaginal delivery. Sometimes we that analgesic spinal dose should be administered for second stage of labor and vaginal delivery, and epidural catheter should be used to extend the block if cesarean delivery is required. Should not administer single shot of analgesic spinal dose because it will not adequate when cesarean delivery is required and cost too much motor block for effective pushing and vaginal delivery, sir. If method of delivery is second method, sir. If method of delivery is first twin is vaginal delivery and operative delivery of twin B. Occurs this type of method of delivery occurs in non-vertex presentation like an external cephalic version followed by a resumption of labor, or internal podalic version and total breech extraction, or performance of C delivery, sir. In this, flexibility associated with epidural analgesia is especially advantageous once if determines for cesarean delivery. Administer non-particulate antacid at the first sign of obstetric concern, and inject addition of local anesthetic to extend the surgical sensory level up to approximately T4 level, sir. Sometimes in special situations like prolonged fetal bradycardia or umbilical cord collapse, or if any inadequate neuraxial anesthesia cannot be achieved rapidly, can administer general anesthesia, sir. This can be avoided if both level and density of the analgesia are optimized at the time of delivery of twin A. Anesthesia provider should be present in the room and give attention to both the fetal heart rate tracing and the obstetric and the mother, sir. If if the method of delivery option for internal podaric version and total breech extraction of twin B, better to perform procedure shortly after delivery of the twin A, before the uterus and the cervix begins to contract, sir, which will be facilitated by epidural anesthesia and sometimes by pharmacologically sublingual NTG around 400 mics, or IV NTG 150 to 200 mics, or intravenous terbutaline 250 mics, sir. Hello? If above procedure is unsuccessful, then have to convert it to RSI with rapid sleeper intubation with GA high concentration of volatile halogenated agents, sir. If method of delivery, third option, if method of delivery is cesarean delivery, epidural, spinal, or GA can be safely be administered, sir. During neuraxial blockade, if either hypotension or occult spinal hypotension is detected, which reduces uteroplacental perfusion, left uterine displacement or displacement to other side may resolve the problem, sir. Greater cephalad spread of the neural blockade is occurs during this neuraxial blockade, sir. During combined spinal and epidural, allows better spinal, and if required can prolong the blockade and with epidural, sir. During GA, which causes increase in oxygen consumption and decrease in functional residual capacity, which may increase the risk of maternal hypoxia during periods of apnea. So adequate denitrogenation and pre-oxygenation required, sir. Presence of more than two twins, which leads to increase in uterine incision and delivery internal. Umbilical cord blood acidemia which occurs, which leads to neonatal depression, sir. In any case, individual skill in neonatal resuscitation should be immediately available, sir.
Finished?
Yes, sir.
Very good. It was a detailed presentation, very well scripted. As Professor Vasanti was asking, how to decide whether you have to do a cesarean for the second baby. Supposing you allow normal vaginal delivery, the first baby is delivered. There is a delay in the second baby coming out.
When
take a decision whether the cesarean should be performed or not. Is it the physician or the anesthetist?
Physicians.
Physician will have to prove that. So what are the criteria by which you will decide? You should have an idea, no? When you are called to attend on a multiple gestation patient, what are the criteria with which you have to be prepared to give anesthesia for the second delivery and the delivery of the second fetus?
When fetal bradycardia or
what
any
is the normal easy method of delivery? When will both the fetus will come out easily? In which presentation it will come out easily?
Vertex presentation, sir. Cephalic
Both are
presentation.
vertex. That's called vertex presentation, isn't it?
Oh,
So
yes,
if
sir.
both are vertex in position, they will come out easily one after another. But if supposing one is having a vertex and another is having a breech presentation, that can be antenatally found out, both by clinical examination or by ultrasonography, isn't it? So you
Yes, sir.
must, the physician will caution you that the second baby is not in a vertex position, it is in the breech position. So we may have to do a cesarean for the second baby. So we must be aware. So in a labor ward, supposing the first baby has come out and there is a delay in the second baby coming out. Do you shift the baby to the, patient mother to the OT and then start the surgery, or how is it managed?
First delivery will be done vaginal, sir. If second twin is,
See,
sir.
antenatally, it has been found out that one baby is having a vertex presentation, another baby is having a breech. Okay,
Okay, sir.
so
Okay,
they want to give a trial and they start the procedure in the labor ward, not in the OT.
okay.
So first
Okay, sir.
baby is delivered without any problem, but the
Okay,
second baby is not coming out. What will you do?
We'll do first external podalic version if they will try, sir. If they can't, they will do under cesarean section, sir.
That's what I'm asking.
Sir,
The transportation from labor ward to OT, how is it done? That is the question I'm asking.
in putting the patient in left lateral position.
Left lateral. So then the OT and labor ward should be very close to each other. There should not be a one labor ward in one corner and OT in another corner. It cannot be done. Okay.
Yes,
So you
yes, sir.
must make sure that the OT and labor ward are adjacent or very close so that patient can be easily shifted from the labor ward to the operating room. Okay. So for the second delivery, what anesthesia you will give? Mother has already delivered one baby. Will she be very tired, exhausted, or will she be very fresh like a normal elective cesarean section mother?
If epidural is there, we can use that thing
No,
for
no
second.
epidural has been given.
So can convert it to GA, sir. By administration.
Why can't you give a spinal? There is only one fetus instead which has to be delivered.
By putting the patient in that rapid second intubation is best, sir. By putting the patient in sitting or lateral, it will take time
You want to make a mother sit up after the delivery of the first child.
It will consume time.
That question only. See, when you are transporting the mother in the lateral position or the tilt, here you have to give spinal in the lateral position. Okay, so don't make the mother sit up and try to give the spinal like you want to do for an
most of the time in our days we used to give only in the lateral position. This new thing about sitting and giving spinal itself is something which has come in the last few years. So it used to be always right lateral or left lateral. If it's cesarean, it will be left lateral. If it is otherwise, it will be right lateral, always. So sitting up and giving spinal has come only recently. So lateral, giving a spinal in the lateral position is very, very safe. It's safer than in the sitting posture, especially after this mother has delivered the first baby. Okay?
Okay.
Yeah.
That's only a practical point. So do not make the mother struggle by making her sit up, and she will be in labor pain also. If there is, as you said, if there is no epidural has been given and the normal vaginal delivery has been, trial vaginal has been given, and first baby is delivered, don't make the mistake of making the mother sit up and then give the spinal. It is easy to give it in the lateral position itself. And then turn her and do the cesarean and take the baby out. Okay, so that is what. And what about the blood reservation for multiple gestation pregnancy? Should it be reserved or it should be immediately available, cross-matched and kept ready?
It should be reserved, sir.
No need to keep it cross-matched.
No.
You said the uterine atony is more common.
To maternal complications, sir.
So you have to be very watchful, isn't it? You don't know when
Yes, sir.
which mother is going to bleed like mad. So
Yes, sir.
always better to keep at least 4 units of blood reserved ready, okay, as a
Okay, sir.
precautionary measure, so that you don't have to struggle in the last minute. Because of these patients, we do not know which one is going to have a PPH because of the undue expansion of the uterine cavity because of the twin gestation. Okay, so you have to, that is another important point. You have to keep blood ready always for patients with multiple gestation. Okay, it is otherwise a very good presentation. You have covered almost all the points, but I'll just share the same thing